Welcome to Ageless and Outrageous, your favorite podcast about how to age amazingly. I'm urogynecologist and hormone and sexual health expert, Dr. Kristen Jackson. Every week, I share my over 25 years' experience to guide both men and women as they age. Listen as I discuss a variety of topics, including hormone optimization, pelvic floor health, maintaining a vibrant sex life, weight gain issues, and skin, hair, and body changes as we age. It's happening to all of us, so listen for some solid scientific knowledge on how to handle these changes. Tune in for a dose of laughter, knowledge, and an honest perspective on the incredible adventure of growing older. What does it mean when you have pain in your bladder? You've probably been told that it is a UTI, a urinary tract infection, a bladder infection, or a cystitis. Very often, those terms are used interchangeably. But what happens when you're always feeling the pain of a urinary tract infection? I bet your doctor may have told you, I tested you and it's not a UTI, but you're still left with bladder pain. This might be more a chronic bladder issue called interstitial cystitis or painful bladder syndrome. Interstitial cystitis is often called IC, so we don't have to say the entire term every time, and painful bladder syndrome is abbreviated PBS, or sometimes it's called BPS, bladder pain syndrome. They tend to be very similar to each other, so I'm going to discuss them together and then I'll explain what differentiates them. Both IC and PBS are associated with similar symptoms. Pain in your belly. This tends to be right above your pubic bone or somewhere in the lower abdomen. Intense urgency. This is a strong need to go to the bathroom that you can't resist. You've got to stop what you're doing to go to the bathroom. Very often, this urgency does not respond well to our typical treatments for bladder urgency. You may also get some partial relief of the pain when you urinate, and this leads to urinary frequency. Because you don't want to hold urine in your bladder, you're constantly urinating to try to get the urine. It's likely that you won't have urinary leaks. That's not a big feature of this condition. Whereas IC and PBS are more common in women, it can occur in men as well. And it's often misdiagnosed as prostatitis, but there is an increased association with interstitial cystitis in men with erectile dysfunction, depression, and stress levels. So while there's a lot of overlap in the symptoms, they do differ in what causes them. With interstitial cystitis, this is a condition of chronic inflammation in the bladder, whereas painful bladder syndrome does not show any evidence of inflammation. But I really think that these two conditions exist on a timeline together. Many patients can start off with the symptoms of painful bladder syndrome. They have pain, urgency, frequency, but they don't have any signs of inflammation if you were to look inside their bladder. Left untreated for a long enough time, painful bladder syndrome may develop into interstitial cystitis, where the typical findings of inflammation can now be seen. So why does this happen? Well, there are a lot of theories, but as of 2024, we're not 100% sure exactly why these conditions occur. The most popular theory is that it's an autoimmune condition. This is when your body attacks the cells that line the inside of your bladder and break it down. So when the urine goes into the bladder to be stored, instead of just holding it comfortably until it's time to urinate, it seeps into the cracks and breaks in the bladder lining and causes pain and symptoms. We know that interstitial cystitis is very often associated with other autoimmune diseases like Hashimoto's in your thyroid, rheumatoid arthritis, irritable bowel syndrome, and fibromyalgia. Another theory of how this occurs is chronic inflammation from repeated UTIs. Every time we get a urinary tract infection, there's a bacteria in the bladder, which means the lining of the bladder becomes all inflamed. Even if you take the correct antibiotic to kill the bacteria, the lining that is inflamed now has to be healed, so your body sets about healing it. Sometimes before it can heal completely, you get hit with another infection. So you take a second antibiotic, but now the inflammation in the bladder lining is even greater. Your body now sets about trying to heal that inflammation again, and before it can be fully healed, you may get hit with a third infection, and so on. Well, when that situation occurs back to back, sometimes some chronic inflammation is now set up in the bladder lining, and it's very difficult for your body to heal it. Other theories about IC and PBS are that these patients have increased pain sensation in the bladder. Remember that pain is just what our brain is telling us. So a nerve signal goes from the bladder to the brain, and we interpret that as bladder pain or bladder urgency. And there is some research suggesting that the C fibers, which are the pain fibers in our bladder, are upregulated, meaning that patients with IC and PBS actually have more sensitive pain fibers or a higher number of pain fibers. There's also information about mast cell dysfunction or hyperactivity. Mast cells are a part of our immune system, and when they break open, they release histamine, which does cause pain in the bladder. And once again, if your mast cells are unstable and releasing their histamine when they shouldn't, or if they're overactive, patients can have signs of PBS or IC. Often associated with these conditions is pelvic floor hypertonicity or spasm of the pelvic floor. Now, this is a tough one to tease out. Did you have pelvic floor spasm that then led to your bladder symptoms? Or did you have an irritated bladder that subsequently caused your pelvic floor to spasm? So it's which came first. But very often we will see that regardless of which came first, until we treat the spasm or the tightness in the pelvic floor, the bladder can't relax fully. So sometimes we need to go beyond the bladder and treat the pelvic floor to really get to the root of all of your symptoms. One thing about IC and PBS is that it is not always recognized as a possible diagnosis for patients. So very often, patients with this condition will have seen on average 7 different doctors before they can come to a final diagnosis. And that's because, as I mentioned before, it's so common when patients complain of bladder pain to be tested for a UTI or even treated for a UTI without testing and hoping they get better. And that avenue may be fine if you have a one-off UTI, you take an antibiotic, and you never have symptoms again. But when the symptoms persist or return after treatment, we really want to try to interrupt that cycle as soon as possible so that we don't set you on the road to chronic bladder pain. If you do think you're already on that road, it really is best to see either a urologist or a urogynecologist. And of course, we will want to hear about your symptoms, your timeline, what you're feeling. We'll definitely want to rule out things like infection. We often will do some expanded testing for UTIs. We also want to make sure you don't have things that can mimic PBS, like bladder stones or kidney stones or a tumor in your bladder. Very often, part of the evaluation will include a cystoscopy. This is taking a look in the bladder with a little camera. It lets us visualize the bladder lining, definitely look for things like stones and tumors. If you have your cystoscopy done in the office, it's not done to rule in interstitial cystitis. It's really done more to rule out other things that it could be. And there isn't really one test that we can do to say you do or do not have interstitial cystitis. It's not like a pregnancy test that just turns positive or negative. Probably the test that gets us closest to a diagnosis is called a cystoscopy with distension. This is actually a cystoscopy that's done in the operating room so that you're asleep because it can be pretty uncomfortable. During a cystoscopy with distension, we fill your bladder up and take a look around, just like we would normally do in the office. But now we continue to fill your bladder, fill it till it's at its capacity and it's stretched out to the maximum amount. And we'll hold that pressure inside the bladder for 5 minutes or so and then drain it out. Now, when we take a look at the bladder after the distension, we can look for those classic cracks or breaks in the bladder lining that are associated with interstitial cystitis and that chronic bladder inflammation. So that helps us to get as close as possible to a diagnosis for your bladder pain. In addition, if we see those cracks and breaks in the bladder lining, very often we can cauterize them shut, which helps them to heal faster and really helps resolve the bladder pain. But obviously, having a cystoscopy and distension means going to the OR for a day. It's an operating room procedure. So before we take patients there might be a lot of things that we can do to try to treat your bladder pain beforehand. First thing to understand is that it's probably not going to be one single treatment for your chronic bladder pain. And also that bladder pain may flare and remiss. So you may have a period of weeks or months where the bladder pain is really significant, and then it may naturally calm down, and you may have a period of weeks or months where you feel like things are going really well. So what has worked to try to keep patients out of the flares of bladder pain are, number one, removing bladder irritants. There is a whole list of foods and drinks that have classically been shown to irritate the bladder. I'll include a link to these foods and drinks in the description, in the podcast description, so you can take a look at it. Not all patients are sensitive to all the foods and drinks on the list, but it's a good place to start. If you're having bladder pain, I tell patients to put a check mark on the list for any foods or drinks that they may have had in the last 12 hours. Every time you have a bladder flare, you keep putting the checks on the foods that you've ingested in the last 12 hours, and you'll start to see a pattern emerging. Certain foods and drinks may always flare your bladder, other foods may do nothing for it. Second thing to do is to stay well hydrated. It may seem counterintuitive, since bladder pain causes frequency and urgency. You're constantly running to the bathroom. You may decide to limit your fluids so you don't have to go as much. But this is actually counterproductive. When we limit our fluids, the urine is going to become more concentrated, and concentrated urine is going to irritate and burn the bladder more if you have those cracks and breaks in your bladder lining. So staying well hydrated is key. How you know if you're hydrated enough is by checking the color of your urine. As long as your urine is clear yellow or light yellow, you're doing fine. We don't want your urine to be an amber or a dark golden color. That's a more concentrated urine. Third thing to consider is maybe something like pelvic floor therapy, which works on any potential pelvic floor muscle spasm. The pelvic floor is like a shelf of muscle that the bladder sits on top of. So if that shelf is tense and spasmy all the time, you can imagine that the poor bladder sitting on top of it is also going to be a little bit spasmy and want to urinate all the time. By relaxing the pelvic floor and getting rid of that spasm, the bladder, which sits on top of it, can also relax. Pelvic floor therapy is usually done with a pelvic floor therapist. This is a physical therapist who specializes in the muscles and nerves of the pelvic floor. They can identify any trigger points in your pelvic floor and try to release them, and that's been very successful at reducing bladder pain. Another thing you can do on your own at home is try the difference between hot packs and cold packs to your bladder. Some patients respond better to hot packs on their bladder, like a hot water bottle, moist heat. It vasodilates, it opens up the blood vessels, and they can get some relief. Other people feel better with a cool pack to their bladder, numbing that pain. One therapy that I do very frequently in my office for chronic bladder pain syndrome is a series of treatments called bladder lavages or bladder installations. During this therapy, we mix together a cocktail of liquid medication and place it into the bladder so it can saturate into those cracks and breaks in the bladder and start to soothe them and heal them. The bladder lavage procedure itself just takes minutes. You come on into the office. We use a tiny little catheter to drain out any urine from the bladder and then pass the medication right back into the bladder. Once the medication is in the bladder, we ask you to hold the fluid in there for up to 30 minutes, and then you can urinate it out. Typically, bladder lavages are done on a weekly or twice a week frequency for several weeks to reduce the bladder pain and inflammation. What I love about bladder lavages, though, is that they are so safe to do because the medication goes into the bladder, treats what it needs to, and then comes right back out. So it doesn't interact with any oral medications you're taking, and there really aren't any side effects to it. There is one FDA-approved medication to treat interstitial cystitis, and the brand name for that is called Elmuron. Elmuron's been on the market forever, and it does work pretty well, but it can be difficult to take. It's meant to be taken 3 times a day, but you usually can't start by taking it 3 times a day. It'll give you too much GI upset. So you have to start it at once a day for a week to 10 days, and then increase to twice a day for a week to 10 days, and then see if you can get to the 3 times a day. Even taking it in that way, there can still be some stomach upset with it, and some women do experience some hair loss. Of course, no woman wants to worry about that. But most concerning about Elmuron is that in recent years, there's been a rare association with Elmuron and a certain type of retinopathy, a problem in the eye. Now, this association is not fully understood, but due to that, and due to the difficulty in taking the Elmuron, it's usually not one of my favorite medications to start with. I like to try to treat the bladder pain and inflammation without that medication. But Elmuron is the only medication that has actually been shown to help heal the cracks and breaks in the bladder lining. That's actually its mechanism of action. If we don't want to use Elmuron, there are some other medications that have been used not necessarily to heal the bladder lining, but to change the way we experience pain from the bladder. Those are things like gabapentin and amitriptyline. Now, amitriptyline in its normal doses is used as an antidepressant, but when we use it in very low doses, it acts as a neuromodulator, which, just like it sounds, means it's changing the way we experience our nerves, in this case, our pain nerves. Amitriptyline has been very effective in really low doses at bedtime in controlling bladder pain. So even though our knowledge of bladder pain is not complete, it's definitely important to understand that all bladder pain does not equal a UTI. And if you are not feeling better after a typical course of antibiotics, especially if you're not feeling better and your urine culture has come back negative and hasn't shown any signs of infection, we really need to be considering these other causes of bladder pain, or maybe seeing a specialist to see what else it could be besides your typical bladder infection. Thanks so much for listening to today's episode. No information from this recording is intended as a diagnosis or treatment for any disease. If you are enjoying the show, please subscribe so you don't miss any of our exciting episodes. And we love to hear from our listeners and would be grateful for your positive review. We'll talk next time.